Okay, so today I'm going to talk about tumor regression and allograft rejection after administration of anti-PD-1. This is my social media. My name is Andrea Masillo. So next we have definitions. What is tumor regression? Tumor regression is a decrease in the size of a tumor or in the extent of cancer in the body.
Today, we'll be discussing the basics of organ rejection. But before we do that, we must first understand a little bit about the immune system. The immune system functions to protect your body against all foreign bodies, which include bacteria and viruses. But how does the immune system work exactly? The immune system recognizes the presence of bacteria or viruses by identifying specialized proteins on their surfaces called antigens. If the immune system detects a threat, it activates an immune response which attacks the foreign body. Now, let's talk about organ transplantation. Organ transplantation is often the only treatment for end-stage organ failures. In Canada, there are over 2,000 organ transplantation surgeries every single year. However, the demand for donor organs continues to outnumber the supply, as thousands of Canadians remain on the waiting list for organ transplants every single year. So what exactly causes organ rejection? All tissues in your body possess unique antigens that help identify themselves to your immune system. However, when someone receives an organ transplant, the antigens on the donor organ are recognized as foreign, and thus an immune response is initiated, which eventually leads to the rejection of that organ. As mentioned before, this process is normally reserved for fighting bacteria or viruses, but in this unique case, the immune system starts attacking the donor organ. There are 3 different types of organ rejections, all of whom vary depending upon how long it takes for the donor organ to be rejected. First, there's hyperacute organ rejection, which happens almost immediately. Second, there's acute organ rejection, which happens after a few weeks of receiving a donor organ. And finally, there's chronic organ rejection, which happens over a long period of time, typically years. After hearing all of this, you may be wondering, how can someone prevent organ rejection? Currently, the most common way of preventing organ rejection is through immunosuppressant medications, which artificially suppresses your immune system. Moving forward, the future of organ transplantation looks very bright. Currently, there is research being done which looks at the possible alternatives for organ transplantation, which may completely eliminate the possibility of organ rejection. The first is stem cell generated organs, which uses the recipient's own stem cells, which have the ability to differentiate into any cell in the body to replace damaged cells of an organ. The second is bioartificial organs, which use artificial materials to substitute the function of a deficient organ. Since these artificial materials do not have any antigens on their surfaces, the possibility of rejection is practically eliminated. That's all for this video. Thanks for watching, but please be sure to subscribe to the Demystifying Medicine YouTube channel.
Okay, next we have what is an anti-PD-1? It's a monoclonal antibody directed against programmed cell death 1, ligand 1, PD-L1, with immune checkpoint inhibitory and potential antineoplastic activities. Okay, so next we have applications in medicine. We report a case in which PD-1 antibody was administered to a solid organ transplant recipient with metastatic cutaneous squamous cell carcinoma. The patient had a robust anti-tumor response along with allograft rejection. This case suggests that anti-PD-1 can be highly effective against cancer arising in the context of chronic immunosuppression. It also suggests that the PD-1 pathway may be critical in maintaining the partial tolerance that prevents T cells mediated allograft rejection.
We've been very interested in studying the microbiome in melanoma patients. We believe that the microbiome has the ability to modulate responses to therapy in melanoma patients, and this is based on pioneering studies that have been published in the field over the past few years, which have shown that specific bacterial taxa within the gut microbiome have the ability to enhance responses to therapy. So most of this work has been done in preclinical setting, so we decided to take it one step forward and study it in the context of melanoma patients themselves. So we started this protocol about a year or so, more than 2 years ago actually, and have now accumulated a large cohort of greater than 300 patients. Among them, our most homogeneous subset was the group who were treated with anti-PD-1 immunotherapy, hence they became the focus of our current analysis. We collected oral and gut microbiome samples at baseline before patients started therapy, and also, if possible, we collected a subsequent longitudinal sample in order to assess the stability of the microbiome over time. When feasible, we also collected tumor biopsies and blood samples from these patients at matched time points to be able to correlate what was happening in the gut with what is happening in the tumor site. So the first question we asked was, is there an association between diversity and response to therapy? So diversity can be thought of as the distribution of all bacteria in a community. So higher the diversity, more the bacteria there are. So in our studies, we found that within the gut microbiome only and not the oral microbiome, that responders had a much higher alpha diversity compared to non-responders, and that this was also associated with significantly longer progression-free survival. Having seen this, we also wanted to look at specific bacterial taxa and see if any of these taxa were more in responders versus non-responders, and that truly was the case. Again, only in the gut microbiome, where we saw that bacteria belonging to the Ruminococcaceae family were highly enriched in responders, whereas those that belong to the Bacteroidalis order was enriched in non-responders.
Okay, so next we have pros and cons. Pros: evaluation of the patient's serum of antibodies to HLA class 1 and 2 antigens and angiotensin 2 type 1 receptor antibody was negative. The excised kidney contained many infiltrating PD-1 positive T cells and PD-L1 positive and PD-L2 positive endothelial cells, and immune cells associated with primarily findings consistent with cell-mediated rejection introduced by blockade of the PD-1 pathway. Cons: 2 months after the initiation of anti-PD-1, the patient had acute allograft rejection. Despite administration of high-dose glucocorticoids, the patient's transplant kidney did not recover. Histologic and immunohistochemical evaluation of the explanted kidney revealed severe acute and chronic cell-mediated rejection.
The role of the immune system is to protect the body from foreign invaders. Normally, the immune system responds to tumor cells as it does to any foreign invader, by destroying them. T cells play a central role in this immune response to cancer. T cells are primed and activated by dendritic cells within the lymph nodes. They can then infiltrate the tumor microenvironment, which is comprised of tumor cells and other tumor-infiltrating immune cells. Here, the activated T cells detect, bind to, and kill tumor cells. Programmed death ligand 1, or PDL1, is one of the inhibitory ligands that, under normal conditions, help maintain immune homeostasis. However, in many cancers, PDL1 can help tumor cells evade the immune system, particularly when it is expressed in abundance. This occurs when activated T cells release interferon gamma, leading to overexpression of PDL1 on both tumor-infiltrating immune cells and tumor cells. PDL1 interferes with the body's anti-cancer immune response by binding to its receptors B7-1 and PD-1 on the surface of activated T cells, thereby deactivating the T cell's cytotoxic activity. T cells can also become deactivated when PDL1 expressed on tumor-infiltrating immune cells binds to B7-1 or PD-1.
Okay, so next we have issues of light color. There have not been any cases reported with this treatment, but the viscosomycin made a section information about this treatment in 2016. Finally, we have conclusion. The latter finding contrasts with those of our earlier report, in which 2 organ transplant recipients with melanoma who were treated with anti-cytotoxic lymphocyte antigen 4 did not have rejection of the transplant kidneys, perhaps suggesting that the CTLA-4 pathway may play a lesser role than the PD-1 pathway in transplant tolerance. We speculate that PD-1 pathway agonists could be useful in the prevention of allograft rejection.
Hello and welcome to Dana-Farber's Science Illustrated. Today we're going to be taking a closer look at how scientists use drug agents to help our immune system discover cancerous cells. Our bodies are made up of trillions of cells which work together to keep us healthy. One group of white blood cells, known as T cells, act as our own personal guards. They patrol our bodies relentlessly for signs of infection or other diseases and attack them aggressively. While on patrol, T cells use specialized protein receptors on their surface to latch on to cells and fully inspect them for signs that they may be cancerous. Once they've made a confirmation, T cells summon an attack on diseased cells. However, sometimes the T cells aren't able to recognize the bad cancer cells and they never attack. Scientists have found that many cancer cells carry proteins that act like masks and allow them to blend in with healthy cells. One protein in particular that cancer cells use for this deception is called PDL1. When T cells use their PD-1 protein to latch onto cancer cells' PDL1 protein, they're fooled into thinking that cancerous cells are actually healthy ones. They then leave the cancer cells alone and allow them to go on multiplying in the body. Scientists realized that if they could find a way to block PDL1 on cancer cells, then the T cells could unleash an attack on them. This discovery led to the development of drugs made from natural human antibodies that block PD-1/PD-L1 protein interaction. The T cells are then able to recognize the cancer cells and begin their attack. Thank you for joining us on this brief look at the exciting field of immunotherapy. For more information, visit discovercarebelieve.org. And until next time, this has been Dana-Farber's Science Illustrated.
Okay, so that's it. Thank you for watching.